achondroplasia, polydactyly and syndactyly of the toes, and mental retardation. Coming to the ocular examination, vision in the both eyes is 636 unaided. With glasses, it's improving to 69. Slit lamp examination shows normal anterior segment, and fundus examination in both eyes show clear media with pale disc, which is normal in size and shape and distinct margins, and there is narrowing of the vessels with foveal reflex, and the background retina shows bony specular pigment dispersion in both eyes. And these are the images. The first image is the right fundus, second is the left fundus, and there is polydactyly and truncal obesity. The second case is a 16-year-old male patient who was brought to the ophthalmology OPD by his father with a complaint of decreased vision associated with night blindness since 6 years, which is progressive in nature. Family history shows second-degree consanguineous marriage of the parents, and the 16-year-old boy has a younger sibling who is normal. On examination, the child presented with truncal obesity, short stature, premature graying of hair, polydactyly and syndactyly of the fingers, and there are learning difficulties and mental retardation. Ocular examination, vision in both eyes is 636 unaided with glasses improving to 69. Slit lamp examination shows normal anterior segment, and the fundus examination in both eyes shows clear media with pale disc which is normal in size and shape and distinct margins, and there is narrowing of the vessels and foveal reflex is present, and the background retina shows bony spicules in the mid-periphery region. And these are the images. The third case is a 12-year-old male patient who was brought to the female patient who was brought to the ophthalmology OPD by her mother with a complaint of night blindness since 3 years, which is progressive in nature. Family history shows consanguineous marriage of the parents, and the child has no siblings. On examination, there is truncal obesity, short stature, premature graying of hair, polydactyly and syndactyly of the fingers, and mental retardation. Ocular examination, vision in right eye is counting fingers up to 4 meters unaided with glasses improving to 6.9, and in the left eye it's counting fingers up to 5 meters with glasses improving to 6.9. Anterior segment appears normal in both eyes, and fundus examination both eyes show clear media with pale disc, a normal size and shape with distinct margins, and narrowing of the vessels is present. Foveal reflex is present, and the background retina shows bony spicules in the periphery with a tessellated background. And these are the images. Bardet-Biedl syndrome is a rare celiopathic human autosomal recessive genetic disorder affecting multiple organ systems. It is characterized principally by the cardinal symptoms of marked central obesity, night blindness, polydactyly, mental retardation, hypogonadism. Apart from the cardinal manifestations, other features include various degrees of intellectual impairment, congenital heart block, brachycephaly, deafness, and dental abnormalities. The primary clinical features include rod cone dystrophy, postaxial polydactyly, central obesity, cognitive impairment, hypogonadism, complex genital anomalies, and renal dysfunction. And the secondary features include speech disorders, strabismus, cataract, astigmatism, brachycephaly, syndactyly, developmental delay, ataxia, diabetes mellitus, nephrogenic diabetes insipidus, left ventricular hypertrophy, or congenital heart disease. And the presence of any 4 primary features or 3 primary and 2 secondary features is required to diagnose Bardet-Biedl syndrome. It is differentiated from Laurent-Moon syndrome, in which paraplegia is associated with Bardet-Biedl syndrome features. Electroretinography can support the signs of retinal dysfunction in early cases that have not yet manifested on retinal examination, which shows diminished A and B waves at both scotopic and photopic light levels. Patients and their families should be referred to genetic counseling for evaluation upon clinical diagnosis, and there is no therapy to treat the cause, but multidisciplinary care is required to treat the disease manifestations, and patients should be given low vision aids as indicated. Annual, if required, more frequent follow-up should be done. And these are the references. Thank you.
Thank you, Dr. VINEELA. Over what period of time did you record all these cases?
1 year.
1 year you got 3 cases.